Okay, well, good afternoon, everyone. I am Jennifer Peel, and I am the director of the University of Washington's Center for Mental Health Policy and the Law. I am delighted to moderate today's session, the next session in our series on hot topics in mental health and law, civil commitment. I am delighted to be introducing and moderating the session today with Dr. Sarah Kopelovich, who is a core faculty member in our center, and she'll be speaking on an academic state community partnership to create a CBT continuum of care for involuntary committees in Washington state. Before I turn it over to her, we do have a few logistics slides to review. So for those who don't know about the Center for Mental Health Policy and the Law is housed within the University of Washington's Department of Psychiatry and Behavioral Sciences in the UW School of Medicine. It's our mission to address the most urgent issues arising at the interface of mental health and the law in order to help justice-involved people with mental illness lead full and productive lives. This is just after the midway point of our series. And if you have not yet registered or learned about future talks in our series, I encourage you to explore the upcoming talks, and we welcome you to join us. Our next one will be on April the 1st. Today's session will be recorded, and the recording will be made available on our website within 1 week. Continuing education is only available to attendees who attend the live Zoom session. There will be certificates of attendance available for attendees who indicate interest. For UW faculty and staff, you will receive an email from the center with instructions. For non-UW learners, we do track your attendance with your unique Zoom link. For disclosures, our speaker today, Dr. Sarah Kopelovich, has no financial relationships with any ineligible company, nor do any of the planners for this series. If you do have questions, I encourage you to use the Q&A icon there on Zoom. We are hoping to reserve some time at the end of today's talk to address some Q&A. And we do also bank all of the questions that we get, and we're hoping to use them in future talks, including our last session of the series, which we will invite all panelists to return for further discussion. And some final logistics, you should know that all opinions expressed today are the views of the speaker and do not reflect an official position at the center or UW. No official support or endorsement of the opinions described in this presentation is from the center or UW, nor should it be inferred. There are automated captions available. Just use the control toolbar, and we will be having an evaluation poll at the end of the session that we encourage you to complete. With that, let me briefly introduce our speaker, Dr. Sarah Kopelovich. She is a forensically trained clinical psychologist in the Department of Psychiatry and Behavioral Sciences at the University of Washington. She's an associate professor, a core faculty member for the Center for Mental Health Policy and the Law, and she holds the first professorship of cognitive behavioral therapy for psychosis. Dr. Kopelovich is a principal and co-investigator on federal, state, and county-funded initiatives to implement evidence-based mental health practices, including cognitive behavioral therapy for psychosis, coordinated specialty care, and digital mental health interventions. She's a founding member and current president of the North America CBT for Psychosis Network, the mission of which is to advance the dissemination of high-quality CBTP across North America. She is a terrific colleague and great personal friend, and I am so excited to hear her talk today. Turn it over to Sarah.
Thank you so much, Dr. Peel. I get to spend the next hour talking about what I love most, and that is, this is work that has been built over the course of the last decade that has really been a collaboration between myself at the University of Washington, my state partners, primarily at the Healthcare Authority, and community partners to create a continuum of cognitive behavioral therapy across Washington state. And of course, for the purpose of this series, I'm going to be focused on the work that we've done to enhance access to this intervention for individuals who are experiencing an involuntary treatment But I think you'll see the full breadth of the work that we've done through the course of this presentation. I will spare everyone the recitation of the learning objectives. You'll see this slide again throughout the talk to signpost where we are across these different objectives in the talk today. I think it's helpful, we had a talk last month where we heard from individuals with lived experience, and it was really helpful to really understand their lens, their perspective, and how their perspective was informed by their experiences. My perspective has been informed by the work that I have done as a forensic and clinical psychologist across levels of care in 4 different states. So I have worked in a children's advocacy center in Manhattan, diagnosing and providing psychotherapy to children and adolescents with abuse histories. I've worked at the Bronx Mental Health Court with a program called TASK, which has kept thousands of New York City residents with mental illness out of jails and prisons and into substance abuse and mental health treatment. I've worked on a forensic unit in the Mount Sinai Hospital system, where I conducted psychological assessments for patients with serious mental illness and cognitive and neurological disorders that were often critical factors to their legal charges. I've provided dialectical behavior therapy, which is a variant of cognitive behavioral therapy, to individuals who were mandated to outpatient therapy as an alternative to incarceration for assault and domestic violence convictions. I've also worked in a maximum security forensic hospital with individuals on various types of commitments, including those who were acquitted, not guilty by reason of insanity, those who were too mentally ill to remain in a mental health unit of a state prison, and individuals who were undergoing inpatient restoration of competency to stand trial. And I served both in a clinical therapeutic role and also provided forensic assessments to other patients in that system for the courts. And then finally, I've worked in intensive outpatient, inpatient, partial hospitalization programs, an assertive community treatment team, a first episode psychosis team, and general adult outpatient mental health programs in Georgia, New York, California, and Washington. So I have really worked across these settings, across these levels of care, at both the individual level with patients, with families, with clinicians, and then also moving into these past 10 years to the system and policy levels. And these have given me a lot of insight into the pain points that have been experienced by all folks who interact with the American mental health and forensic systems, and why it is that in each of the 4 states I've practiced psychology, I have heard the refrain, our state's mental health system is by far the worst. Civil commitment is not just a complicated moral, ethical, and psycholegal issue, it's also a deeply personal issue that impacts thousands of Americans and their families each year. Being trained as a dialectical behavior therapist, I am really familiar with this concept of the dialectic, which is where we have 2 supposedly contradictory truths. And I think a core dialectic that I hear around that has framed this issue of civil commitment is around this tension between civil liberties. So here the thesis is that individuals have the right to make decisions about their own mental health, and that includes the right to refuse treatment, versus the antithesis, which is that this idea of social responsibility in the context of poor diagnostic insight. So, for example, that we have an obligation to intervene to prevent a near-term harm. And synthesizing these dialectics requires stepping out of our binary thinking to truly understand the complexity of this mechanism of treatment. We have to understand the full scope of the factors that are involved in civil commitment. So oftentimes the issue gets reduced to one factor, namely, insight. This helps us see the full context of this issue and the factors that actually lead to a civil commitment. And this is from a model called the socio-ecological model. It's been widely applied in public health, behavioral health, healthcare system design, because it acknowledges that health outcomes are influenced not just by many factors, but by multiple levels of factors, from the individual level to that broad policy and societal influences. And so we can use this model to help us alter the factors that are within our control, and then to account for those factors that may be outside of our control. So often this debate becomes centered on the individual factors, right? Insight, judgment, treatment adherence, and it can fail to acknowledge the community or the system of care factors that contributed to the need to leverage this treatment mechanism of involuntary commitment, right? Of involuntary treatment. And namely, and this is what I'm most passionate about, that these individuals did not have access to high quality evidence-based care in the community, where that care was also coordinated and consistent across providers or settings. So this model helps us understand that civil commitment exists within this context of a severely under-resourced system that functions as almost all crisis and no catch. Much of my work of the past 10 years has straddled each of these levels, right? To leverage the factors in each that can support better health outcomes and better community tenure for Americans with a psychotic disorder. So I'll be talking today about cognitive behavioral therapy, which is an evidence-based psychotherapy that I have personally seen change and save lives. But I quickly learned when I came to this state 10 years ago and started to try to really get this disseminated, that training the workforce to deliver CBT is all for naught if we are not creating interpersonal system of care and societal changes that create the infrastructural supports for these interventions within our public behavioral health setting. So I really want, this is the full continuum of psychiatric care as it should exist, right? And on the left-most side of the screen, we have the settings that are most restrictive, most associated with restrictions on civil liberties, all the way to those that are least restrictive to an individual's rights and liberties. And I want to just emphasize a few points here. One is that no intervention or implementation strategy can compete with the impact that pure availability of resources has on the likelihood for rehospitalization. First and foremost, we need housing, we need step-down programs, we need residential programs, and we need social services to support vulnerable populations that have episodic conditions like schizophrenia spectrum disorders. Moreover, it's not enough to have these levels of care available. We also need to ensure that healthcare and allied practitioners within these settings are all adhering to the national treatment guidelines for the conditions they treat. And I would argue that the onus, our responsibility for providing evidence-based care is higher the more restrictive the treatment setting is. And so when we're talking about civil commitment, we have a secure facility with a population that has been mandated to hospitalization. Our responsibility to provide the highest quality care is no greater than in that context. So our reality across all the states that I have both worked in and consulted to is that, one, we have major gaps in the availability of programs between these ends of the spectrum. And I would encourage each of you to think about which of these programs exists in your counties, right? I'm sure you're painfully aware of these gaps of services. Two, we have major deficiencies in the quality of care being provided within each treatment setting. And then three, we have little to no continuity, communication, or coordination of care across these treatment settings. And so this state of affairs of care discoordination and care discontinuity is a leading factor in that socio-ecological model of civil commitment. So here are our national schizophrenia treatment guidelines for schizophrenia spectrum disorders. I had the privilege of being involved with in a systematic review that was the primary evidentiary source document for this updated practice guideline published in 2020. I had no involvement whatsoever in how they translated those findings into these guidelines or how they framed them. When I accessed the treatment guidelines, and by the way, they have a version for clinicians. They also have a version specifically for families and individuals with lived experience. And I found something in that version for families that I had never seen before. And I'll just zoom in on it here. It says medications are a complement to psychosocial treatment and are an equally important part of the overall care process. This was notable because it's the first time that that APA has recognized medications as a complement to psychosocial interventions instead of the other way around. And I think for families and for clinicians to really internalize what this shift means, it really does mean that we have to have a much more expansive model for understanding the origin of schizophrenia spectrum disorders and their treatment, their holistic treatment in care settings. The reality, the state of the field in the US is that roughly 1/3 of Americans currently are not accessing any kind of treatment in their lifetime for a serious mental illness. Among those who do access treatment, they are 3 times more likely to be treated in a forensic or criminal justice setting. We do have some updated numbers on this underway right now by a SAMHSA-funded prevalence study that just wrapped up, and which our center, the Spirit Center, had some involvement with. So I'm excited to see what those findings suggest. And then based on a national point prevalence estimate that I conducted a few years ago, looking specifically at the accessibility of CBT for psychosis, I found that only 0.3% of Americans with a psychotic disorder had received a session, even a single session of CBT for psychosis. That is excluding first episode psychosis programs, which typically have that included as part of their care model. And so what we're looking at just in terms of our workforce numbers is about 15 CBTP trained providers for every 10,000 Americans with a psychotic disorder. So all of that was really just intended to help us frame the issue. We're going to talk more specifically now about what cognitive behavioral therapy for psychosis is, and I want you to walk away with it knowing at least one prominent finding associated with its evidence base. So let's talk about what it is first. And obviously, we're going to be quite brief here, given the time allowance. Cognitive behavioral therapy is a form of talk therapy that helps people identify and change unhelpful thoughts and behaviors. It is based on the idea that the core of the human experience is one, our ability to construct meaning from our experiences through thoughts, beliefs, assumptions. We're going to call that the interpretation. 2, our emotions, which consist both of our feelings and also the physical experience of our emotions. And then 3, our behaviors, and that each of these elements of the human experience are interconnected. Each impacts the other. So CBT for psychosis is a specialized adaptation of CBT that's designed to help people experience symptoms of psychosis like hallucinations, delusions, negative symptoms. And I will say that contrary to some bad press that I think CBT sometimes gets, neither CBT generally nor CBT for psychosis specifically teaches people that their thoughts or beliefs are wrong and need to change. Rather, it's really about bringing awareness to how the individual has made meaning of their experiences, where that came from, and just to be able to identify how that's impacting how they feel to start to learn some new strategies to better cope with distressing experiences. I will say that we as clinicians or as family members often get quite fixated on behaviors of individuals with serious mental illness, because these can be quite concerning, right? Things like self-harm or neglecting to care for your basic needs. But individuals experiencing a serious mental illness tend to be far more preoccupied by their physical or emotional distress, fear, paranoia, frustration, hopelessness. And there's little that we can do just to make quick shifts in those feelings directly. But we have decades of research that proves that when we can make changes in these other elements of the model, we can drive down the distress considerably to the point where people can live well in the context of symptoms. So I want to give an illustration of how how CBT can support the hospital course of an individual on civil commitment. We're going to talk about Jed. Jed is currently on his second 90-day ITA extension. He has lived with voices and paranoia for more than 20 years. He's estranged from his family, including an adult son. And over the years, his untreated psychosis has gotten so severe that he will sleep outdoors, really only going to the shelter when the weather is too severe. And because his baseline anxiety and vigilance is so high, he is highly vulnerable to anxious interpretations, even of neutral or vague, ambiguous stimuli. So for instance, Jed assumes that all black cars are mafia, that they're there monitoring him, that if they have a chance that they will poison him or attack him. He engages in safety behaviors like carrying knives and a metal pipe on him for self-defense and only eating prepackaged foods. And these behaviors create a false sense of security, of safety, but ultimately they reinforce his belief that he is at risk of harm by others, and therefore they perpetuate his paranoia. Just prior to this hospitalization, he lost 35 pounds from lack of food and sleep. He's put some of that weight back on in the hospital, but he continues to report without a shadow of a doubt that he is being targeted by others. And so he doesn't want to leave the hospital, where he has a locked room on a secure unit. He's resistant to discharge planning, and he won't commit to changing self-neglect or defensive behaviors. Clients like Jed pose real challenges to our system, and they should make crystal clear the need to address both the practical factors associated with hospitalization, like safe housing and social services, and the psychological factors that precipitated the hospitalization, right? Namely, this maladaptive threat response cycle that's maintaining his distress and disability. So what would have happened to Jed in a typical hospitalization course is they would have, if he was amenable to medications, they would get him on medication or adjust the medication. If not, they would be trying to work with him to commit to a safety plan when he leaves the hospital. What is happening right now, because he is actually at one of the hospitals that we're working with, is he's working with a psychologist on exposure to feared situations, first imaginal and then progressively more real life types of exposure. Starting to get some attentional training so that he's also attending to safety cues in his environment and not just what he's interpreting as danger cues. Working with his son to develop trust and start to generalize feelings of safety outside of the hospital environment. So this kind of intervention it is the most well-researched psychological intervention for psychosis. CBT generally has more than 60 years of empirical evidence. CBT for psychosis specifically has over 30 years of empirical evidence. And it is statistically and clinically, we see significant improvements in the delusional conviction or the preoccupation the individual has with delusional ideation, hallucinations, illness awareness. But I really want to have an asterisk there because What is much more important in CBT than somebody saying, I have schizophrenia, I agree with my diagnosis, is that they have awareness and insight into the things that make their symptoms or their experiences worse and those that make them better. And we do see improvements in that type of insight through CBT. Medication non-adherence tends to improve. It's one of our primary outcomes, as well as negative symptoms, which are generally less impacted by CBT for psychosis, but we do seek improvements nonetheless. And the more we're fine-tuning the treatment to target specific psychotic symptoms, the more we're seeing the clinical efficacy of CBTP improve. On the basis of this substantial evidence base, in 2020 and a little into 2021, I partnered with the Substance Abuse and Mental Health Services Administration to author this CBT for psychosis implementation guide. I want to just give a credit. This work would not have been possible without the professorship in CBT for psychosis. SAMHSA was not able to pay for this product to be written. And so this was only possible through the professorship. And it led to the first and heretofore only dictum that we have ever had from the federal government stating that CBTP should be implemented within our mental health systems, and CBTP informed care, in other words, CBTP skills, at a minimum should be implemented in primary care, correctional, forensic, and educational settings. So this really is the kind of recommendation from the federal government that we should be providing access to this intervention wherever individuals who would presumably benefit from it are presenting for care. So we're going to move into now some of the benefits of incorporating this intervention into the standard of care for involuntary treatment. And this whole slide is really pulled from that SAMHSA CBTP implementation guide, where I go into much greater detail on each of these, after also having outlined the incentives to individuals who are participating in the treatment. So what we see at a systems level is that CBTP aligns with the mission and value of healthcare organizations. Generally, evidence-based treatments are positively correlated with healthcare quality, safety, and client outcomes. So that makes sense. We see good economic value of CBTP, both in the short term after the treatment, and then when we look at some longitudinal studies. CBTP is squarely aligned with and really a critical component of a recovery-oriented system of care. It is compatible with measurement-based care, which all of our systems should be adopting. It is valued and well tolerated by both service users and their families. And when we train practitioners in CBTP, what we find is that it also enhances some of those core psychotherapeutic competencies that then generalize to their patients with other kinds of presenting problems. So now let's talk about the efforts that are underway in Washington to enhance continuity of care across inpatient, outpatient, and specialty care settings. So when I came to Washington in 2015, there was, I think there was there's one psychologist who was in the UW medicine system who was providing CBT for psychosis during, I think he had maybe one clinical day a week. He had also trained some practitioners at Western State Hospital to facilitate a CBTP group, which I'm not sure how consistently that was being held. Other than that, it was very difficult to access CBTP across the state. Since 2015, I've braided philanthropic and state funds, and most recently county funds. King County has just recently made significant investments in expanding access to CBT for psychosis to develop one of the most robust CBT for psychosis provider networks in the country. And this work has been done through my other center, which is the Spirit Center, where we have a CBTP training team In addition to working with our community behavioral health agencies, we have also trained the assertive community treatment teams in Washington on either CBTP therapy or CBTP skills training. We've also provided all of the training, consultation, and technical assistance to our New Journeys First Episode Psychosis teams in Washington State. And then more recently, the state rolled out intensive residential treatment teams to help support individuals once they're discharged from long-term hospitalizations or an involuntary commitment. And we have started to work with those teams to train them in CBT core competencies. And I'm pretty sure we're missing a couple of our newer IRT teams in Washington State. But what you can get a sense of is really just this network that we have built of both outpatient programs and specialty treatment teams that have really been getting the same kind of training from the same trainers on how we're delivering this intervention to individuals in these different programs. So we built a lot of infrastructure in our state for CBT and CBT informed care, but we continue to struggle. We have continued to struggle with discontinuity across care settings. So one of the things that we did that was really different from what's happened in other places with regard to workforce development is that historically each discipline has their own siloed training that create these conditions under which each practitioner is speaking a slightly different language, right? They have different perspectives on the etiology, the sequelae, the indicated approaches for schizophrenia spectrum disorders, or even psychotic symptoms generally. And the result is this discontinuity of care, both across and even within a given treatment team. And then beyond that, we've also had families who have been historically omitted from treatment for a variety of factors, the result of which has been this missed opportunity to really create more exposure to the same kinds of concepts and skills. And so from 2017 to today, we have broadened our approach to training so that all caregivers, clinical, natural supports, allied, are developing core foundational and functional competencies that are associated with recovery-oriented psychosis care. And actually, just last Thursday, I gave a just mini workshop to the Washington State Office of Public Defenders, right, who also come in contact with our folks with serious mental illness and also need to learn these same kinds of core competencies. And we can train them not to be practicing therapy. We don't want folks practicing outside of their scope of practice, but rather to train them to the height of their practice on these CBTP concepts and skills. And there we have everybody speaking the same language, but people have different dialects based on their unique lens, their scope of practice. And what we've done that in doing that, we are not only reaching more people who were training in this intervention, but we're also reaching more people with the intervention itself. So if we have a service user who has access to peer specialists, to their family members, to case managers, they can get some of these foundational concepts and skills. And we can go all the way up to what is a much more limited resource, which are advanced clinical specialists who can provide the psychotherapy. So this model has been laid out in a paper I wrote in 2019 with colleagues. And then also we looked at our outcomes, both our quantitative and our qualitative outcomes. And I don't have time to get fully into our qualitative findings, but in terms of our quantitative findings, we found that the reach of our intervention exponentially increased through this stepped care model, that we were able to reach 3 times the number of providers, and we were able to reach more than 3-fold the number of clients who received access to the intervention. During the course of the 12-month training program, 80% of our 165 trainees were able to attain competence. And when we followed up with them 12 months later, all 4 of the agencies we had implemented CBTP stepped care in had sustained all 3 levels of care, which were CBTP individual therapy, we had group CBTP, and then we had CBTP skills, kind of low intensity version. 81% of the folks we had trained were still delivering CBTP at that 12-month follow-up point. And when we asked each of our groups of trainees, they endorsed high levels of acceptability, high levels of feasibility to implement the intervention in their care settings. And then they 91% found that it was appropriate for their settings. And we found no differences in these perceptions across the groups. So the CBT Care Pathway Project is a more recent, it's sort of the next step that we took, that we started in 2023. And it's intended to enhance the quality of care for individuals on a civil commitment in Washington State and the continuity of care. So this is really known as a transitional intervention. It is an intervention that's aimed to start CBTP on the inpatient unit when somebody's hospitalized, and then to help them transition to CBTP in a less restrictive environment. Our specific goals were to enhance access to CBTP for Washington State civil committees, to support the successful transition from inpatient to outpatient care, to enhance continuity of care for individual patients that are transitioning from one setting to another, and to reduce 30-day rehospitalizations. This was a true co-production effort between myself and my team at the University of Washington, our partners at the Healthcare Authority, and our community partners. And this really allowed us to really think about this holistically and make sure that we each kind of are thinking about different aspects of that socio-ecological model that I referenced earlier. So my contributions as an academic clinician were really in synthesizing the body of empirical knowledge about CBTP, about organizational change theory, and how to implement CBTP in inpatient settings, as well as those transition interventions. The state was really my thought partner in considering those societal and system of care factors we saw on the model, and our community partners lent critical insights into the individual, interpersonal, and community factors, really essentially telling us what was and was not possible, which was really critical information. And so this is an overview of the components of the care pathway. Every element on this model that you see in green font indicates something that all of the partners agreed should be happening and was feasible to implement. So obviously CBT for psychosis is on there, but we also have to be training in motivational enhancement strategies, because not every service user is going to be asking for or wanting to receive psychological treatment, right? So how do we help build that motivation to make changes? Family engagement, right? So we're really thinking about all of these green elements are things that can and should be happening at each phase of the care pathway. Anything you see in yellow font is a want to have, but something that would be really challenging to implement, at least in the near term. And then the red font indicates things that just were off the table, that could not happen. And that was unfortunate, because it turns out that meeting with the outpatient provider when you're on an inpatient unit, from the based on the evidence base, based on work that's been done in the UK, is one of the most effective ways to get somebody to show up for their first outpatient appointment after discharge. But this was a real roadblock that our partners were not able to address in the short term. So just to give you an overview, we have, this work is ongoing. We had partners, different partners in Pierce County in 2023, one that had an inpatient program, the other that had an outpatient service. We had 2024 new partners that had both an inpatient and outpatient service. And in 2025, we're working across an inpatient site in King County, as well as in Kitsap County, a healthcare organization that has inpatient, residential, and outpatient treatment. Let me just give you an overview. And these outcomes, these implementation outcomes are in process. Our first year sites, which were sites 1 and 2, 2 being outpatient, 1 being inpatient, our outpatient site was able to take up CBTP. They offer both group and individual CBTP at their agency now. They are also adherent to our care pathway model. Our inpatient site started offering group CBTP 5 times a week on 2 units. That was a huge success, but they were not able to be adherent to the care pathway. There were a lot of things that got in the way, including just staff changes and staff shortages. And similarly, our inpatient outpatient partner in our second year, they had staff turnover. Mind you, we're still in the pandemic. Their staff turnover contributed to their decision to drop out altogether. The inpatient site really struggled. They were able to offer what we call milieu CBTP, which is really creating a skills culture on the unit. They were not able to launch group or individual CBTP on their inpatient unit, and they were not able to get to adherence with the CBT care pathway protocol. 2025 has been off to an amazing start. We have our inpatient site, I should say both of our 2025 sites, we're starting with just getting everybody, as many people possible, trained in CBTP, getting that off the ground, and then starting with our care pathway protocol in 2026, which starts July 1. And so we have all of our sites for 2025 are now offering both group and individual CBTP. At site 4, we've trained 101 staff in CBTP core competencies and 3 staff in doing the intensive individual psychotherapy. At site 5, we've trained 59 staff in these foundational core competencies, and we have I can't remember, 5 outpatient, 3 residential, and 3 inpatient staff facilitating the CBTP therapy. So capstone reflection, implementation work, particularly when you're doing it in collaboration with your partners, with your stakeholders, is incredibly hard work. Think about that socio-ecological model and all the factors that we have to account for to really start to create system change. And there are many factors that were not on that slide. I really want to give a huge shout out to my colleagues at the UW Spirit Center. This is our core CBTP training team. And these folks are just incredibly gifted clinicians and trainers. And Sydney McKinstry is our program coordinator, who just does an incredible amount of work to make sure all of these trainings happen. And the Washington State Healthcare Authority, who has funded this work. Also, this work, as I mentioned, has been supported through private philanthropy as well, that has really helped to create some opportunities to fill in funding gaps. So I'm going to leave this slide up for a little while as we start to turn towards our Q&A section. There are a lot of resources if you're interested in learning more about the work that we're doing. If you are a family member or caregiver who wants to get trained in CBT, core strategies and techniques that you can use with your family members, I encourage you to visit the Psychosis Reach website. And then the North American CBTP.org site is that organization for clinicians. I encourage you to visit it, become a member, and look at our CBTP competency criteria. And I believe that Selena is going to push these links, or already has pushed these links into the chat, so you all can access them easily. Jennifer, I think I'll just leave this up for a little bit as we turn our attention to the Q&A.
Terrific. Hey, Sarah, that was such a instructive and thoughtful talk. We really appreciate it. And I see that we already have several questions coming in. For those who just listened to Dr. Kapelovich, I encourage you to ask additional questions, and we'll try to get through as many as we can today. You just touched on this, Dr. Kapelovich, right at the very end of your talk, but we do have a couple of questions about getting more access to training, particularly if you are a caregiver or a parent or family member of somebody with lived experience and you want more exposure to CBTP. Can you walk us through the steps to try to get connected to some of these resources?
Absolutely. So for families and caregivers, I strongly recommend the Psychosis REACH training. REACH stands for Recovery by Enabling Adult Carers at Home. This was an intervention. This is just really probably some of the most meaningful work I do, and that's saying a lot. This was an intervention that was kickstarted in 2018 by a family member in Washington State named Marianne Osborne, who attended a NAMI convention, National Alliance on Mental Illness, and she saw one of actually the two treatment developers for CBT for psychosis, Doug Turkington and David Kingdon, talk about the fact that we can teach families some of these concepts and skills that we're teaching clinicians, not so that they can be therapists to their loved ones. That's absolutely inappropriate, but really so that they can enhance the communication and start to repair the relationship and create conditions under which recovery happens. And so she came back to me and said, we have to make this happen. We have to start training family members. How can we make this happen in Washington State? And initially it was through philanthropy that we were able to develop this into a fully fledged training for family members, which launched in 2019. And now it is partially state funded and still funded through philanthropy that has been provided for free to family members all around the world. So we have trained about 5,000 family members to date in, I want to say, something like 20 different countries. It is a multi-component training. So you will do some of it on your own through an e-course. You'll come together with other family members for a guided workshop. And then you have the opportunity to get paired up with a family member with lived experience. We call a Psychosis REACH Family Ambassador. And I know we have a few actually on this webinar who can provide some emotional support and skills coaching in these interventions. If you are a clinician or an allied professional who would like some training in CBTP, whether that's to do therapy or just to do more CBTP informed care, I encourage you to either visit the uwspiritcenter.org website. We focus primarily in the Northwest region of the US, but we have contracts with other states and counties outside of Washington as well. Alternatively, you can also go to the nacbtp.org website where you'll find other training offerings on their training page.
Very helpful. It sounds like the excellent resources available for individuals who might want to learn to be trained in this. Sarah, what if you have a family member or a patient that you want to try to get connected to this modality? How can we find resources for them?
That has been one of our most pernicious challenges. One, just simply because of the lack of availability of trained providers. I mentioned the statistic earlier of less than 1% of our behavioral health workforce as of 2021 had been trained in CBTP. And then what compounds that issue is that nobody really advertises for the service. In fact, I remember a few years ago, this was pre-COVID, I had myself a letter writing campaign to the director of Psychology Today because psychosis was not listed as one of the treatment targets in their online therapist directory. So it's just really difficult for folks in the community who are looking for this intervention to find it for a host of reasons. This is something that I'm working on through the North America CBT for Psychosis Network. I'm currently the president of the organization. One of my strategic objectives for my presidency is to create an online directory of CBTP therapists in the United States. So that I expect to be coming online, if not in 2025, then early 2026. We've got a lot of wheels in motion on that front. In the meantime, if you're in Washington State, you could see from the slides the agencies where we have trained. I will say sometimes when we are going in and implementing CBTP in an agency, we could only be training a handful of staff, right? Some of these agencies are quite small, and mental health workforce turnover is at least 50% every 2 years. So just because it's on the map doesn't mean that they have somebody right off the bat ready to work with you or with your loved one. But it's definitely worth starting there. And you can always reach out to UW Spirit Lab at uw.edu. We also keep a list of providers who we have trained, or agencies who we have trained, or private practitioners who have told us that they're trained in CBT for psychosis.
Looks like there are some questions about advancing this modality even further. One question is, for the future, how do you imagine AI may intersect with either training in CBTP or the delivery of CBTP by trained professionals?
So I received a grant in 2019 that's actually just coming to a close next month from the National Institute on Mental Health. And the intention of this grant was actually to develop an AI-enhanced CBTP training tool. And the impetus of this was that there's only so many CBTP trainers in the US, right? And so psychotherapy and CBTP specifically, training is incredibly costly, time intensive, right? And when we're dealing with that workforce turnover rate of 50% every 2 years, it's very difficult to think about a scalable model of psychotherapy training, but that is our charge. That's exactly what we need to be doing. Well, one way that we can do that is by leveraging the technological advances that we've seen, particularly in natural language processing and machine learning, to help us to fill in some of the gaps that experts, master trainers are not able to attend to. And so this tool that I developed, it was through iterative testing, is now a fully functional training tool where folks can log in and they can learn a little bit about a specific CBTP core competency, and then they can immediately put that into practice with a simulated patient who appears on their screen in the same way that a telehealth patient would be on their screen. The patient gives a little prompt, they then record their response, and the AI is able to analyze their response in real time and provide them both with a score and also with some qualitative feedback. Now, this doesn't replace the role of comprehensive training, but it's a great way to start to develop those core competencies, or for somebody who has already been trained, to help them to avoid some of the drift that can happen over time.
Dr. Kapelovich, you gave so many great facts and details about local services. We have some questions about how this may be implemented in other areas. Curious about other states and also data from the UK, particularly if this is being utilized. Is there any longitudinal outcomes for rehospitalization or justice involvement that you're aware of?
Yeah, we do have data looking at hospitalization as one of the primary outcomes for CBT for psychosis. And we do see that CBTP can prevent hospitalization or rehospitalization. It has also been associated with shorter inpatient stays. So definitely an indication there for introducing CBTP wherever somebody presents. And I think one of the ways that we have to think about it, this intervention is there are so many things with our folks that are experiencing serious mental illness, particularly if they have been experiencing it over the course of years or decades. There are so many things that we need to address. It can feel really challenging for the clinician to do a time-limited intervention like CBT, because it just feels like there's so much. There's sleep disturbance, there might be substance use, there might be depression, right? And we also see higher rates of cognitive challenges with this population, or we might see higher rates of traumatic brain injury. So lots of factors that make this work really challenging. The more we can be introducing CBTP where folks are presenting, the more penetration of the intervention we get, and the bigger impact we'll see on individuals' lives and their functioning. Our colleagues in the United Kingdom are at least a couple decades ahead of us in terms of the implementation of this intervention. So CBT was developed here in the US. The Brits were the ones that were really responsible for applying it to psychotic symptoms, and they have been doing a lot of the work in creating some of the system conditions that are needed to keep this intervention on the menu. Whereas in the US, we have taken a much more biomedical approach to treating serious mental illness. And as a result, we see far fewer psychological interventions in treatment. They have, in the UK, I've spent some time over there learning from some of their leads in the NHS, to see how is it that this is so much more, the penetration of CBTP in the UK is so much higher than it is in the US. One, I'll say they have their challenges too. So it's not to say it's ubiquitous, but it's definitely it's definitely easier to access than here. And one of the reasons for that is that they have a whole professional development program, a CBT certification program that is started off when somebody starts working with an agency. They have a 2-year training program built in to their work. And so a portion of their time is spent at the training institution, getting trained up in CBTP, getting tapes rated for competence, and then they're building their caseload over time. So they've really mastered this, creating space for learning CBTP and delivering it to clients.
Very thoughtful, super helpful content, Dr. Kapelovich. Really want to thank you today for all of this, really fruitful information, resources, and data. We're in our last minute, so I do want to thank you for this great talk and guidance. And if you could advance the slide, we'll introduce next month's speaker. So do just want to share with everyone that we will be continuing our series next month with a talk on April the 1st, put on by Dr. Silver. And this talk will be on a new topic for the Center's series, and this will be on essentially navigating juvenile involuntary commitment with a particular focus on Washington State. If you could advance the slide once more. Our center really appreciates any feedback, so we will be sending out post-event surveys, and if you could complete the survey, that really does help us improve and develop future sessions. Okay. Again, thanks so much, Dr. Kapelovich, for all of you who joined us today. We do hope you join us for future sessions in this series as well. Have a good afternoon.